Hi, I'm Dr. Paul Mason, and today I'm going to dispel some myths about back pain. You know it's a bad day when you're being carted from your house to a waiting ambulance by firemen. And here he is again, a few moments earlier, a 43-year-old male who developed severe low back pain after CrossFit. At the hospital, he was diagnosed with non-specific low back pain, filled to the eyeballs with drugs, and discharged home, still largely incapacitated. And here he is 3 weeks later, off all drugs, back at work and regularly exercising, including resistance training. So how did he get from the back of an ambulance sucking on a green whistle to regularly exercising with no drugs in only 3 weeks? Well, it started with an appreciation of what was likely to be causing his pain, followed by some evidence-based interventions. Let's now take a detour looking at the science of spinal pain. Unfortunately, contemporary thinking on low back pain has us throwing in the towel when it comes to diagnosis. Take this 2017 review on low back pain. It explicitly claims that most low back pain has no known pathoanatomical cause. Basically that we don't know what causes most cases of low back pain, and for the most part, shouldn't bother trying to figure it out. The logical conclusion of this defeatist approach is that patients get lumped with a diagnosis of non-specific low back pain and oftentimes recipe-style treatments. The source of much low back pain, however, both directly and indirectly, is the intervertebral disc. Of course, the prevailing opinion is that discs don't contribute to pain due to the absence of any significant innervation. And to counter that claim, I submit this. Stained in red are nerves. It's now well known that intervertebral discs, even healthy ones, have a nerve supply, at least to the outer surface. Not only that, but many of these nerve endings are C-type fibres, known to specifically conduct nociceptive or pain signals. So then, why did a scientific review conclude that there is no known pathoanatomical cause of low back pain? Scientific snobbery. Basically ignoring any research older than 20 years. For example, of 141 references in this review, only one was from before the turn of the century. This represents a huge volume of lost knowledge. 72 years ago, for example, Swedish orthopedic surgeon Carl Hirsch provided direct evidence that intervertebral discs could be a source of pain. He inserted a needle into the lower discs of 16 subjects with lower back pain, and in all cases, either the insertion or subsequent movement of the needle reliably reproduced their pain. And after they felt pain from the needle, he injected a small volume of local anaesthetic into the disc, and every single one of these subjects in whom he injected the local anaesthetic experienced complete relief of their pain. Direct evidence that discs can cause pain. And the knowledge that discs can cause pain has been known for more than 90 years. Articles published in 1930 and 1932 in the French literature clearly describe subjects reporting the disappearance of low back pain following the targeted injection of local anaesthetic. And also published in 1949 was a paper by another Swedish surgeon, Gunnar Wiberg, which clearly proved the pain-sensitive nature of the intervertebral disc. He performed back surgery on 200 conscious patients using only local anaesthetic for analgesia. That's right, every one of these 200 patients was awake. And through the careful use of local anaesthetic, he was able to expose the intervertebral discs without anaesthetizing them. He then set about, in his own words, firmly probing the discs to see what they would feel. And in almost all of the 200 patients, he was able to generate low back pain in what was described as a lumbosacral distribution. In other words, irritating the disc caused non-specific low back pain. Subsequently, in 1958, Professor Michael Joseph Smythe from England published a paper with further direct evidence that irritation of the outer part of the disc, the annulus fibrosus, could cause low back ache. After operating on a patient with a nerve root compression, he passed a nylon suture through the outer part of the L4-5 disc, the annulus fibrosus. He then closed the wound with the free ends of this nylon protruding from the skin. Then, the day after the operation, investigators tugged on the nylon loop, and after about 30 seconds, the subject described the onset of an ordinary backache. In other words, direct stimulation of the L4-5 disc led to the production of something we would now term non-specific low back pain. And more recently, from 1991, we have this paper. A series of 193 patients were, as with Gunnar Weiberg in the 1949 paper, operated on while conscious. Using local anaesthetic to numb the superficial tissues, the investigators were able to expose the discs without anaesthetising them. And then they used both blunt compression and electrical stimulation on the exposed disc to assess the pain response. In 2/3 of the 191 subjects, this stimulation of the annulus fibrosus always reproduced their preoperative back pain. That is, it qualitatively reproduced their pain, identical to their usual low back pain. Further evidence that disc irritation can lead to so-called non-specific low back pain. And one consistent, though surprising, finding common to these experiments is that the pain reproduced by irritation of the discs often had a muscular quality. In other words, the pain mimicked muscle pain. Consider for a moment, how many patients have you seen who have presented describing their low back pain as muscular? Often without any unusual activity that would be expected to cause muscle soreness or injury. Furthermore, pain will often be unilateral after activities such as squatting, which use the muscles in a symmetric manner, or with no evidence of muscle tear or contusion. Remember, patients often can't tell the difference between muscle pain and disc pain. And the innervation of spinal discs explains how they can cause a muscular type pain. The sinovertebral nerve carries the sensation from the disc, and this feeds into the sympathetic chain. In fact, the sympathetic chain carries 90% or more of the sensation from the lumbar discs, a fact which has been known since at least the 1940s. And any pain that is transmitted by sympathetic fibres is by definition visceral referred pain, often poorly localised and intense. These nociceptive signals do not follow the usual route of somatic pain, such as might be expected with a muscle or ligament injury. Rather, pain from the disc travels through the sympathetic chain, making it a visceral referred pain. Consider, for example, the pain of a heart attack. Carried along sympathetic nerves, this too is visceral referred pain and is often referred down the arm or into the jaw. And because it's a visceral pain, it's often mistaken for muscular pain. In fact, about 20% of patients experience a heart attack describe their symptoms as relating to muscle pain. Now, as well as being a direct source of pain, disc pathology can also cause pain indirectly by compression of spinal nerves. Here, for example, from a 1959 paper, you can see how an intradiscal injection can increase disc bulging with subsequent impingement upon a spinal nerve root, and you can see two patterns of pain result. As well as the shooting pain going all the way down to the hand, there's a less precise pain around the shoulder blade. And this is important to know. Compression of a nerve root, depending on the severity, can lead to two distinct patterns of pain. We're all aware of the radicular type of pain from a nerve compression, but this is a relatively late presentation, indicating relatively significant nerve compression. But irritation of the outside of a nerve, which can either be chemical or mechanical, without disruption of conductance can lead to a less precisely localised pain mimicking muscle ache. In other words, a progressive nerve root compression, one would expect to see a muscle ache type pain before the onset of classical radicular pain. And to understand why this occurs, consider that nerve roots at the point where they're usually irritated by discs are covered by a pain-sensitive layer called dura. Pain sensitive because this dura has a rich nerve supply, as you can see here. And as with the nerve supply of the disc, it feeds firstly into the sinovertebral nerve and then into the sympathetic chain. And remember, Pain conducted by sympathetic nerves is visceral referred pain, and this occurs before the onset of classical radicular symptoms. It is this anatomical fact which means that the nerve root irritation often presents quite differently to what is commonly presumed, and I believe this leads to misdiagnosis in many patients. In fact, I submit that misunderstanding of the visceral referred pain patterns from irritation of the nerve dura has led to the widespread acceptance of many musculoskeletal syndromes for which there is actually very little evidence. Piriformis syndrome, trochanteric pain syndrome, levator scapular syndrome, quadrilateral space syndrome, ITB friction syndrome, sacroiliac joint pain syndrome, T4 syndrome, the list is long. I first considered the possibility that nerve pathology could present as a poorly localised pain after a patient with long-standing sacroiliac joint pain had a CT-guided injection for another problem, and his sacral pain disappeared. He was an elite athlete with a long history of sacroiliac pain who had the recent onset of classical radicular symptoms down his leg, and after a CT-guided injection targeting the S1 nerve, not only did the pain in his leg improve, but his sacral pain completely disappeared. And for more evidence that irritation of the dural sleeve surrounding nerve roots can cause pain mimicking these syndromes, we return to the 1958 paper by Professor Michael Joseph Smith. A total of 37 subjects underwent open surgery for back pain, during which they also had loops of nylon thread passed around one or more nerve roots. The thread was left to come out of the skin, after which the wound was closed. Then, after the surgery, the investigators, in their own words, gently pulled on the threads, and what they found was two reproducible patterns of referred pain, what the authors termed neuralgic pain and myalgic pain, as in muscle pain. One of the patients in this study had the thread passed around his right S1 nerve root, and this is the account. 36 hours after the operation, there was complete relief from sciatica pain. The nylon thread was exposed and a gentle pull exerted on it. The effect was immediate. The patient jumped and exclaimed that a severe pain shot into the right buttock. It disappeared at once when the nylon was relaxed. At the second attempt, the thread was very slowly drawn upon until the patient could feel pain. This time, it was not so intense. The thread could be barely touching the root. Then, tension was increased, and as it mounted, severe pain spread from the centre of the right buttock down the centre of the back of the right thigh. It appeared to consist of two components: a sharp pain, which ran as if down a line to the extremity, and a deep, boring, aching, unpleasant sensation felt diffusely in the soft tissue. And this is clear evidence that nerve root irritation can present both as muscle pain and classical radicular pain. Another patient in this study felt pain in the area shaded in red after tugging on the thread around the left L5 nerve root, a pattern closely resembling what is often diagnosed as piriformis syndrome or sacroiliac joint syndrome. And I often see patients with pain a little further out laterally being treated for greater trochanteric pain syndrome. And in the same patient, this was the pattern of pain from irritation of the left S1 nerve root, which affords some understanding of the condition commonly referred to as back-related hamstring pain. In yet another patient, S1 irritation produced a localised pain liable to be diagnosed as ischial bursitis or proximal hamstring pathology. Now, we know that sitting is associated with increased pressures within the lumbar discs, and this can be a source of nerve root irritation. And that all of the syndromes I've just mentioned are known to be exacerbated by sitting is therefore relevant and consistent with them being caused by irritation of the nerve root dura. These pain patterns are also well known by neurosurgeons who document the progression of symptoms from nerve root compression in their patients. They note that the symptoms usually begin as a perception of muscular aching before they progress to the more classical radicular symptoms. And cranial nerve root irritation too can lead to muscular type pain. In this 2006 paper from Japan, it is noted that patients with cervical nerve root compressions frequently report muscle aching around their scapula. And so, in 50 patients who underwent cervical nerve root decompression surgery, a pain map was recorded around the shoulder. Changes in pain were then assessed after surgical nerve root decompression. A relatively predictable pattern of pain attributed to different nerve roots was identified, and, as with lumbar nerve root irritation, cervical nerve root irritation is often diagnosed as various syndromes. This can include levator scapular syndrome, T4 syndrome, quadrilateral space syndrome, and numerous other obscure conditions. And as with the lower limb syndromes, these syndromes are frequently considered to be posturally exacerbated, again suggesting nerve root dural involvement. Now, one thing I've observed is that in many patients suffering low back pain, with clear neurological findings on examination, is that these findings are often ignored in favour of implausible diagnoses. Take, for example, the association of low back pain with gluteal weakness. The gluteal muscles receive supply from both the L5 and S1 nerve roots, which is why involvement of these nerves can lead to gluteal weakness. This is why both a Trendelenburg gait and gluteal wasting are considered potential signs of radiculopathy. The trouble is, rather than considering the possibility that the nerve root irritation may be causing both the back pain and the gluteal weakness, many practitioners assert that somehow idiopathic weakness of the gluteal muscles, occurring for no obvious reason, is the ultimate cause of the back pain. And unfortunately, this thinking has been propagated in the literature. In this study, which documented the correlation between gluteal muscle atrophy and low back pain, it was stated that the muscle wasting may represent incidental disuse atrophy. Of course, with nerve recovery will come muscle recovery, which means that many people on gluteal strengthening programs will eventually recover. Not necessarily because of the treatment, but rather during it, and in some cases, in spite of it. Nonetheless, this observation that recovery of muscle function and improvement in pain coincide only serves to reinforce the cognitive errors inherent in this type of thinking. And this kind of thought process is nothing new. I had my first exposure to it more than 20 years ago when I was taught that dysfunction of the multifidus muscle was the cause of low back pain. The thinking was that patients with low back pain often had disproportionate atrophy of this muscle, and so it must be the cause. Well, multifidus has what is called a segmental innervation, meaning it drives its nerve supply from local levels. The result of a nerve compression is therefore localized atrophy. Multifidus atrophy is not so much a cause of back pathology, but a result. So if you see a patient who's had their back pain attributed to a muscle weakness or a muscle atrophy, please reconsider their diagnosis. Now back to the question of making the diagnosis of nerve root involvement. As always, history is key. In particular, trying to discern between the two types of pain, visceral referred or radicular. When asked to show me the pain, if a patient rather than pointing with a finger indicates the location with a wave of their hand, this much more likely indicates to me it's going to be a visceral pain due to the less defined localization. Also, the history of causative or provocative events. If there's no history of a mechanism that could injure a muscle and no evidence of muscle pathology, such as on imaging, don't diagnose a muscle problem. And as well as a neurological examination, muscle palpation for trigger points can be very useful. Perhaps surprisingly, the presence of these focal trigger points of muscle tenderness and spasm can be highly specific for the presence of nerve root irritation. For example, one study published in 2016 found that the presence of trigger points in the upper outer gluteal quadrant was more than 90% specific for lumbosacral radiculopathy. 90%! That is, if trigger points are found here, there's a 9 in 10 chance that the patient has a nerve root pathology. And compare this with the straight leg raise test commonly used to diagnose lumbar nerve root pathology, which only has a specificity of 26%. This probably also explains the increasing popularity of trigger point needling. When done effectively, patients often report significant pain relief. The problem is, being a treatment to a symptom and not the root cause, relief is often only temporary. And pain can also arise indirectly from disc pathology. For example, from disc space narrowing. Facet joint degeneration usually occurs only secondary to disc space narrowing. In fact, facet joint arthritis without pre-existing disc disease is rare. The reason is that facet joints normally support approximately 20% of the axial load of the spine, but in the case of disc-based narrowing, this load can more than double, and obesity makes this worse, with a BMI of over 30 increasing the risk of facet joint OA by 5 times. Of course, arthritic facet joints by themselves do not necessarily correlate with pain. They can often be seen on imaging, especially MRI scans, quite incidentally, and my preferred investigation for identifying a symptomatic facet joint is a CT SPECT bone scan, followed by diagnostic CT guided injections. And the resultant osteophytic bone spurring of arthritic facet joints, combined with the disc-based narrowing, not uncommonly leads to something called foraminal stenosis, and this can compress a spinal nerve root as shown by the bottom arrow. The symptoms again depending on the degree of severity of the nerve compression. And arthritic facet joints can also impinge on the descending nerve roots in the lateral recess of the spinal canal, presenting very similarly to irritation in the foramen, but requiring very different treatment. And finally, bony spurs on facet joints can also impinge on the back of the spinal discs, as noted in this 1991 paper, and this can cause pain. Another way disc degeneration can indirectly contribute to pain is via bony injury to the vertebral bodies known as modic changes. The strongest risk factor for modic changes is disc degeneration, and it's common to see a kissing type pattern of bony bruising in adjacent vertebral bodies. Another important fact regarding the pain from modic changes is that that too is carried by the sympathetic nerves, meaning it is vague and it's visceral. And as I already alluded to, there's much debate in the role of imaging in diagnosing spinal pain, especially MRI. The most significant criticism, one that is often well justified, is that symptoms are often over-attributed to non-specific findings, such as disc dehydration. The corollary of this is there's some findings that are both obvious on MRI and well correlated with pain. One of these is an annular tear. Here you can see a focus of hyperintensity on a T2 weighted MRI, indicating an annular tear. Oftentimes they're quite small and frequently underreported. They are, however, usually painful, settling down over about 3 to 6 weeks. This then allows for reassurance of the patient. Often after an annular injury, even after resolution of the pain, there's dehydration of the disc. On a fluid-sensitive MRI sequence, these discs will often appear quite dark compared to the adjacent discs. Usually, these are not associated with pain. The problem is, emotive language like disc desiccation and degeneration is often employed when reporting, contributing to fear avoidance behaviours and catastrophization in patients. And disc bulges are also often over-interpreted by both patients and therapists as being a major problem, rather than the common and often incidental finding which they are. Of course, not all disc bulges are benign, especially when it comes to nerve root compression, which can and does cause symptoms. Unlike disc dehydration and simple bulges, however, when MRIs will often detect asymptomatic pathologies, the sensitivity for an MRI in detecting a nerve root compression is actually quite poor. Let me say that one more time. MRIs are not that good at detecting nerve root compression. Many practitioners take it at face value that if an MRI says there's no evidence of neural compression, then there's no neural compression. But they shouldn't. In fact, this systematic review found that MRIs detect only 25% of clinically evident nerve root compression. Now, this is not all that surprising, given we know spinal structures respond dynamically to loading. Many patients with symptoms exacerbated by sitting will report relief in lying. So then we scan people in supine, in lying, spine unloaded. It's predictable that we may miss things which would be detected on a seated MRI scan that would detect dynamic changes. Of course, we now have access to upright MRI scanners, and while these can be useful in some patients, namely those with postural or positional pain, the resolution is less than great. The problem is that the magnets in these scanners are relatively weak, only 0.6 Tesla compared to the preferred 3 Tesla scanners, and magnet strength is a major determinant of image quality. This then leads to a problem where we may suspect nerve irritation but lack the diagnostic tools to prove it. If radicular signs are present, we can usually guess at the level of an involved nerve, but only to within a level or so. The problem being that most areas of the skin are actually innervated by 2 or more nerve roots. Further, published dermatome charts have significant variation between them, as is evidenced by this table comparing those from 7 anatomical texts. Take for instance the lateral aspect of the foot. While usually considered to be supplied by the S1 nerve root, it's not uncommonly supplied by L5. And this was the case in my patient here, who had complete relief of lateral foot pain following a CT-guided L5 injection. And this serves to illustrate the diagnostic value of CT-guided injections. I personally believe they're underutilised, both diagnostically and at times therapeutically. Injections can also help identify the site of a nerve compression, which is important as this can completely change management. Additionally, other structures such as facet joints can be targeted if there's suspicion they're causing pain, and as well as being diagnostic, they can also provide several months of pain relief. This study finding facet joint injections led to an average of 19 weeks of pain relief. Now there's one more quirk about how nociception is carried from the lumbar spine to the brain that can be used diagnostically and therapeutically. We've already seen that a number of structures of the spine can lead to nociception, which is carried to the brain via sympathetic nerves. This includes the disc, the dura covering the nerve roots, and the vertebra themselves. Well, after travelling along the sinovertebral nerve to the sympathetic chain, these signals ascend to the level of L2, where they pass back with the L2 nerve through the L2-3 intervertebral foramen. This means blockade of the sympathetics at this level has the capacity to block the signals from reaching the brain from the spine below it. And this is well known, with sympathectomies sometimes being used for this purpose. This study, for example, looked at the utility of unilateral L2 nerve blocks on the side of maximal pain in 33 subjects with low back pain. Afterwards, all patients reported improvements in their back, buttock, thigh or groin pain, almost completely disappearing in 26 of them. Also of note is that of the 9 patients with sciatica symptoms, only 3 had partial relief, indicating a different pain pathway for radicular pain, as we already know. Furthermore, the average duration of pain relief was more than 20 days, despite the use of only short-term local anaesthetics. And this is not an isolated finding. This randomised double-blinded study found that L2 nerve blocks were still relatively effective even at 30 days. This makes these injections suitable for settling down acute exacerbations of pain. And the prolonged reduction in pain that is often seen with these injections is hypothesised to arise from a reset effect to the sympathetic nerves, which I suspect is central to the etiology of central sensitisation.